Yes, hello, and thank you to the organizers for giving Dr. Fluge and me the opportunity to talk about B-cell depletion in ME and CFS. My talk will be on status for clinical and biological studies, and I have the honor of talking about the old things. Dr. Fluge will tell about what we've been doing for last 1.5 years, and things we're thinking of in the future, and maybe also some speculation, depending on time. Now, initially, I have to say that we have a conflict of interest, and that is that Haukeland University Hospital has patents and patents pending on the issue of B-cell depletion in therapy for chronic fatigue syndrome. And this patent, Dr. Fluge and I have been mentioned as inventors. Our interest in this field, as you probably know, we are oncologists and been working in oncology, clinical oncology, for very many years. Our interest in the field came quite incidental because we had a patient that had had CFS for 7 years, was stable, using a wheelchair most of the time, and she got a lymphoma, Hodgkin's disease. She was treated and had a recurrence, and during the recurrence treatment, she suddenly, 6-7 weeks out into the chemotherapy regimen, got an impressive improvement in her CFS symptoms. It was very unexpected for her and also for us. And later she went on and had high-dose chemotherapy and autologous bone marrow transplantation. And her CFS symptoms came back again. She went to the outpatient department. Dr. Fluge saw her, and they had discussions. And both he and Dr. Fluge were very curious what had happened with her during this cancer chemotherapy. And we sat down speculating and looked at the regimen, the one of the 4 regimens she was given, that she had an improvement in her CFS symptoms in. And that was the so-called IIMEC regimen. It's a 4-dose combination where one of the drugs is methotrexate. And the two other drugs could be occluded because they were given in other combinations earlier without any effect on the CFS. And we found out that maybe the reason for her bettering was a relative B lymphocyte depletion that is seen in rheumatoid arthritis patients being given weekly methotrexate. So because the patient pushed us very hard, we decided to do a therapeutic trial in this one patient, looking specifically at taking down the B lymphocytes. And we could do that in a manner which we use quite regularly in our oncology clinic, namely by giving rituximab, which is a CD20, anti-CD20 antibody, which efficiently takes out the B lymphocytes from quite early stage and up to nearly the plasma cell level. The plasma cells, as you probably know, are the ones that make the antibodies in our body. We knew on beforehand that CFS probably was an immune defect of some type. And we treated this patient, and nothing happened initially. 6-7 weeks, nothing happened. Then she called Dr. Fluge and said, I think something's happening. 2 days later, she was very sure something was happening, and she had a remarkable recovery. And it again lasted for some months. She was treated once again with a new response, with about the same lag time before the response came. So we went to the chairman of the regional ethical committee and asked for permission to treat 2 more patients. And were given that, and we treated 2 other patients, and both these patients had response. Now, after the second patient was treated, we were in a dilemma. We had to find out what were we to do now. This was, quite out of line of our ordinary work. We're in a busy oncology department, have lots of responsibilities there, and on the other hand, this could be very important for this group of patients. We knew that this was a disease no one really knew too much about the etiology of, and we knew that we could be going into both a tough area of research and also an area that would cost us quite a lot of work. But we decided that the only ethical thing to do was to try to do a further study in a systematic way to find out more about this. Of course, the appropriate way to do that would have been to go to phase 2 study with a single arm. But we found out that we couldn't use years of our time doing that. So we also know that no one would believe in the results if they knew everyone had had the active drug. So we found out we had to do a double-blinded, placebo-controlled study. And the number of patients in that study was a compromise between what was practical to do in a busy oncology department without awakening too much fuss from the nurses and the other doctors, and what could give a reasonable chance of getting a significant result if the response rates were high enough. So the number 30 that we came up with was a cynical speculation on our behalf that the response rate was quite high. If it had been lower, we had come out with a negative result. We used this monoclonal antibody, which is partly a mouse-derived, partly a human-derived drug, which is well known from our oncology clinic and is also used in rheumatoid arthritis and some other autoimmune diseases. It is usually well tolerated, although it takes away the B cells. They are virtually gone from the blood for a long period. The patients usually have little infections, and the side effects have been few, especially in lymphoma patients. And as I said, the CD20 is present from quite early in the development of the B cells and up to nearly ripe plasma cells. That is, if you have circulating plasma cells and they are quite long-lived, they can circulate in the blood for quite a long period, and they can keep on making antibodies if there's a need for it. For example, if you get a bacterial infection. So you take all the B cells in the middle. One other observation we had from our pilot series of 3 patients was that it seemed that all the symptoms related to CFS, they diminished in parallel when we gave this drug. And that made us think that the B lymphocyte depletion in some way had to do with the central mechanism in the maintenance of the symptoms in these patients. The 2 first patients, they had an early response, as we call it. 6-7 weeks into treatment, they started getting better. And we here made a little fault because we made a primary endpoint 3 months after start of rituximab, if there was difference in the symptoms in the 2 groups 3 months after. It proved that our 3rd patient, which we got the results from after submitting our protocol, had a so-called late response. She responded 5 to 6 months into treatment, which in fact proved to be the usual pattern in our patients. Last year, we published this study of 30 patients. It was in +1, and it made quite a lot of fuss in our home country. And I went in and looked a couple of days ago. 35,000 have read the article. And good oncology papers from our own department have about 1,000 hits. So it has made some impact on people. Maybe it's the ME patients they're reading. I don't know. Well, what we did was that we gave rituximab 500 milligrams per square, 2 infusions, 2 weeks apart. And then essentially we observed the patients for 12 months. We did not know what we gave. The patients did not know what they got. Nurses did not know what they gave. It was only the pharmacy that made the preparations that knew which group the patients belonged to. So we did as objectively as we could to find out were we really affecting the patients with this treatment. The patients were included according to the Fukuda criteria, retrospectively analyzed. The 28 of the 30 also fulfilled the Canada criteria. First patient was treated in June 2008 and the last in June 2009. And as you know, there are no biomarkers that can be followed, so we had to rely on what the patients told us concerning their symptom changes. The secondary endpoints were the changes in CFF symptoms after 2, 4, 6, 8, 10 and 12 months. And also we looked at overall response, that is symptom bettering at whatever time after treatment. And how the groups put together? Well, they were reasonably well balanced. Rituximab mean 37 years, placebo 31.2, women 80%, duration 5.1 against 8.1. Here it's one patient that draws up the mean. About 70% of the patients had an infection identified or probable infection shortly before debut of their CFS. Concerning disease development up to the time of intervention, most patients were stable or had a worsening up to start of treatment. Another interesting aspect, because at this time we had the thought that maybe this is an autoimmune disease that hasn't been recognized. We went in and looked, had the patients any evidence of autoimmunity, other diseases? Well, some of them had 20 and 27% had some other autoimmune disease. And first and second degree relatives, 33 and 47% had autoimmune disease in the family. The most important thing about this trial is just to show that the groups are well balanced. The symptom score is high concerning feeling of fatigue. 10 is the maximal that they can think of. Cognitive, pain score, and other symptoms. That are the main groups that we registered symptoms within. And we also registered something called an overall CFS score. The patients did the big job for us because they registered what happened to them all the time. Every fortnight, they were asked to register the different symptoms, how they had been looking at the fortnight as a whole. We know that the patients can have variations from day to day, so they were asked to equalize that during a 14-day period and put up a number. 3 is the symptom at the same level as it was when we went into the trial. And up and down is 4, 5, and 6. 6 is a major improvement. 4 is a slight improvement, and the other way down to 0, because you can have both bettering and decreasing of symptoms. And they were in these 4 categories: fatigue, pain, cognitive function, and other symptoms, among them autonomic symptoms, gut symptoms, sleep problems, etc. And here, concerning the other symptoms, we chose the 2 most dominant symptoms characteristic for that patient. So they varied from patient to patient, but they was kept at the same 2 symptoms during the whole trial. And here is a typical symptom from one patient. You see the different colors represent these 4 types of registrations: fatigue, cognitive, pain, other symptoms. We see that generally improvement or worsening of symptoms, they follow each other. You see that this patient has a rather early response, around 2 months, getting a bit better, reaching what we call a significant level at about 3 months, duration for some months, and in fact, as the fatigue is the symptom that we register as the main symptom, this patient is still in response, although he is declining at 12 months. As these curves show from 3 different patients, the pattern varies. Here's a patient that starts off with practically no response, gets better and better, and in fact is still at work now nearly 4 years after, and in very good response. Another patient here with a rather early response, dramatic response, but not a very long duration. Another patient, nothing seems to happen before 6 months. Things happen, and it was, in fact, for this patient, a very dramatic response. She said she hadn't been so well. She was in her 40s since she was a teenager, but it didn't last too long for this patient. And we put all the fatigue scores together. You see the reds are the ones from the rituximab patients, and the black are the ones from the placebo group. And you see that the reds tend to be above the line here. 3 is where they were when they started. Some of the rituximab patients had no response. Others were responding, and we see 2 black spots keeping on those up here. Those are the 2 responders in the placebo group. This slide also shows that there is an interaction with time, significant interaction with time, and there is a great difference in favor of the rituximab group between 6 and 10 months after treatment. So the response to rituximab comes rather late, and that is quite different from many other drugs that you give. We'll come back to that. This study has some exploratory issues in it because we knew very little about how response was to be in these patients. So not all the criteria were defined in beforehand, and that is one of the reasons that we have to have a new study. But looking at what we defined as overall response, 67% of the patients had a moderate or great response, while 13% of the patients in the placebo arm had so. 2 of the patients in the rituximab group are in response nearly 4 years after inclusion into the study. 4 of the patients had response past 12 months, and the mean duration of response was 25 weeks. That doesn't mean that they were at maximal response, but within the criteria we put up, 25 weeks was the period of response according to the definition. In addition to these scores, we also had some standard tests done. For example, SF36 registration. It's a well used and validated scheme. What we can see from this is that the physical health summary score was significantly different concerning the maximal change between the rituximab and the placebo group, which is not quite unexpected, but it verifies what the patients told us. The same is concerning the maximal change in physical function and bodily pain. Social function is a trend, but not significant. What we also can see from this study, from this registration, is that the mental health summary score is not changed. Role-emotional mental health summary score is not changed. And that, again, maybe points that the psychological factors are not the reason for the improvement in these patients. What about side effects? Well, if you look at the infusion-related side effects, there was nothing here that could tell us which group the patients belonged to. For example, nausea was only seen in the placebo group and not in the rituximab group. One thing that we notice here, that the 2 patients who proved to be in the rituximab group had a decrease in function related to their CFS symptoms for a period after their first infusion. And we also had 2 patients reporting uneasiness and sleeplessness for a period after rituximab infusion. The main side effect was, in fact, worsening of psoriasis in 2 patients. They had pre-existing psoriasis in parallel with much improvement in their CFS symptoms. They had worsening of their psoriasis, which could be managed. So it wasn't a really serious problem. So we concluded that we didn't see any real serious side effects. We had no serious infections. We had 2 hospitalizations, one in both groups. One placebo patient had a myocardial infarction, and one patient in the rituximab group had an episode of abdominal pain, which proved to be a corpus luteum cyst, which probably has to do with her hormonal functions coming back in order again. We had several patients having normalization of their menstrual cycle after rituximab treatment, which had been out of function for a long time. One of the other conclusions that we had to make was that the time for response to treatment was from 2 to 8 months. There was no response coming immediately. For example, if you give gamma globulin, human gamma globulin, you usually see an effect within 24 to 48 hours. Nothing was seen of that kind here. And you know that the rituximab virtually clears the blood from B cells within very short periods. Maybe 1 to 2 weeks, they're practically gone. while, for example, some people said that this probably was a virus clearance mechanism, because, you know, some of the virus, they can hide away in B lymphocytes. But then the response should have come much quicker, because the B lymphocytes are practically gone within a couple of weeks. The extent of relief in the patients was very variable, from patients feeling totally well to patients having quite good responses, to patients with more moderate responses, and to a third of the patients not having response at all. That's important to say, that in this double-blind randomized study, a third of the patients did not respond. But of course, that also gives us an opportunity to look, are there things going on in the non-responders that are not going on in the responders, and vice versa? So in addition to these clinical parameters, we were interested in looking at what happened with, for example, other immune cells during treatment. So we did serial blood sampling and banking of these patients all through the study. We looked, for example, at lymphocyte subpopulations, and I'll give you some indication of that. Up on top, we have the placebo patients. Of course, we wouldn't expect anything to happen with them, and it didn't. The red and the blue dots are the responders and the non-responders to rituximab. And there's no difference concerning the degree of clearance of B lymphocytes in the blood. So there's nothing there. Of course, you could say that we haven't looked at the spleen, we haven't looked at the bone marrow. There could be differences there. But looking only at the blood, there's no obvious difference here between responders and non-responders. What about the T cells? We know that when we do something fundamental with one of the players in the immune system, something happens to the others. What about the T cells and the NK cells? And we did the same. We looked up to 12 months, and the reds are rituximab, both responders and non-responders, the black placebo. And we can see from these 4 slides that the T helper cells, the T cytotoxic cells, the T regulatory cells, there's no obvious difference between rituximab and placebo patients. And also concerning NK cells, we can't see any changes that can help us. What about T cell activation parameters? We've looked at 6 different, and again, we can see there's no difference. So I think I will just say a few words about the B cells. We, of course, also looked at the B cell numbers, but as they are very low during a lot of the time, the chances of seeing something by chance is quite big. So I won't say much about that. But we looked into the regulation of the B cells. Could there be something special with these, the regulation of the B cells, since an agent that depletes the B cells can have an effect on the disease? Is there something wrong with the B cells themselves? And we looked at the 2 most interesting growth factors for B cells, namely the BAF and the APRIL. And what has been known about autoimmune diseases is that often patients with autoimmune diseases have increased BAF levels. Here, it's the opposite. From the start, BAF is lower in these patients than it is in the placebos. These are age-matched and sex-matched patients. Not patients, but normals. What about placebos during treatment? Nothing happens to the BAF. But where we have depleted the patients, we get a rise at 3 months, 6 months, and a decrease again in BAF. It's quite a normal curve. It seems that the BAF is functioning as it should in these patients. And we see the same in a later study with the maintenance rituximab, just the same pattern. There's nothing indicating that the BAF system is out of order in these patients. What about APRIL, which is a growth factor that comes in later into the development of the B cells? Is there something wrong with that? I can just say no from these curves. Okay, I think I'll let Øystein continue.